So we're here to have a brief talk with a patient on the table about things that we spoke about when we're talking about cognitive biases. Now, these cognitive biases are the ones that I want to speak about today. Essentially, what you see is all there is. So the information that you have available to you is the only information you'll be able to create an associative picture from. Theory-induced blindness, right? So you believe a theory so much that even when you receive information that would clearly prove it wrong, you are unwilling to change your mind, and you will very, very vigorously defend your theory or your point of view or your belief. And then also just a concept that isn't necessarily part of cognitive biases, but just very poor diagnostic criteria. Right? We talked about osteopathic assessment or assessment within manual therapeutics. The only thing that we're honestly assessing or capable of assessing is motion, be it motion of a joint structure or motion of soft tissues. Whatever it is, we clearly check motion. We don't really check anything else. So as far as the diagnostic criteria are concerned, people speaking about things such as specific nerves, right? So those specific nerves, you can speak about things like symptomatology, changes in sensory output, changes in sensation, changes in motor control, and you can definitely do that. But things such as blood vessels, specific blood vessels, having restrictions on them that are changing functions. Right? You have to be very careful with that because you have no way to prove, at least by today's standards, that that's actually occurring, at least not from the outside or from symptomatology. You can begin to believe that there's something going on and that you then need to have imaging or other things done. As far as people speaking about organs, okay? So if we're working through the abdominal wall, what we're talking about in many cases with osteopathic practitioners or practitioners of other kinds is people will start speaking about specific organs and that they can find problems with these organs. Okay, so if we have the ASIS right here, and right here we have the lower margin of the ribs. Within this region, we believe we have the descending colon, we believe that we have the stomach right around this region, and we believe that if we go a little bit more posterior, the spleen may be present. Okay? We have no way, as osteopathic manual practitioners, of knowing whether the patient has situs inversus or not. So it's entirely possible that anything I palpate here, it's not likely, as far as statistics are concerned, but it's possible that this could be the liver, not the stomach. Okay? Depending on the BMI of the patient, or essentially the level of muscularity, the level of subcutaneous fat or leanness, whichever way you decide to look at that, the abdominal wall or the contents posterior to it or deep to it can be very much obscured. Right? So you will see people percussing for sounds to see if something sounds different than it's supposed to. So a stomach should sound relatively hollow unless somebody's eaten a meal recently and going on down the line. What you will see though is people palpate here, right, and tell you things like the stomach is out of phase, or tell you that the stomach has a lesion, or the stomach has this or that. You'll see people come down to here and palpate through the region essentially where you could separate the external obliques, the internal obliques, not so much the internal obliques here, but especially the external obliques and the rectus abdominis, right where you have a bit of a valley there based on the tendinous sheaths, and you'll say that they're essentially palpating the colon. Well, depending on the patient, the colon could be in a slightly different position, it could be slightly more medial, it could be slightly fuller, slightly more empty. Depends. We don't know for sure unless we have other corroborating evidence such as images. But you'll see people do this, and then they'll be talking about the fact that they're helping peristalsis of the colon. While that may have a possibility of being correct, it may also have a possibility of being incorrect because we're lacking information. The tactile senses that we have, we're going to pick up muscular tone, and we may very well essentially mistake muscular tone for an organ or something else that we think it is. We could think that it's fecal matter within the organ or within the descending colon, and we would have no way of being sure of that. What we would do, though, is if the person says that they're constipated, we treat them, and we add this into the treatment, essentially what some people will call a breakup treatment, right? Or some people will call visceral treatment, or many other names. If we include that in the treatment, we then believe it was, if the patient's constipation changes and they're able to have normal bowel movements, we will say that because we did this, that's why. Right? We will completely ignore that everything else that we did in the treatment, such as, say, treating the lumbar column, or treating the shoulder, or treating anything else that isn't moving as it should. If this area is moving as it should, especially if we compare it to the other side, and the patient's constipated, and we treat this area, we will attribute, so what you see is all there is. Well, I worked in the area of the colon, and as a result of that, the patient is no longer constipated. Well, we don't know why the patient was constipated. We don't know if it was a dietary issue. We don't know if there was a neurological issue. We don't know why. And we will completely ignore everything else that we may have done in a treatment. So this is what you see is all there is. I believe that I worked here because somebody told me that if I work here, that I will essentially stimulate peristalsis in the colon. And so that's a what you see is all there is issue. And then theory-induced blindness. If I believe for sure that if I palpate through this region, I find stiffness, I find firmness, I find difference in motion of soft tissues, that is definitely a problem with impacted fecal matter. Right? So if somebody's taught me that, then I believe that, and I will continue on doing that. So I then have these associative thoughts, which may or may not be true. What I can say for sure is if I palpate stiffness, lack of motion in the abdominal wall through the obliques, that's what I have. I have high tone in the obliques, I have a lack of motion in the obliques, or I have soft obliques, whatever it may be. I can say that confidently because I can palpate it and I can show it. But I cannot necessarily say in a directly related fashion that I have an alteration in the function of the colon. Now I understand that there is mechanotransduction, that mechanical stimuli will alter the function of cells. So it's possible that that's occurring, it's possible that it's occurring to a nerve. It's all possible, but I don't know it for sure. So what I think would be very beneficial for us to say is that we have a motion dysfunction. We assess motion. We can honestly do that, we can truthfully do that, we can provably do that. The rest of it is related information that may be due to cognitive biases.